A warm welcome to all my dear MOS members and the ophthalmic fraternity who have joined tonight for a very interesting series that we have come up. MOS has formed 21 committees. Out of that, we have one committee which is the academic committee, and that all the subspecialty practices we are trying to cover. So this is the first in the series, and we are lucky to have the pioneer of one incision smile with us, Dr. Rupal Shah, who is coached about 1,700 students all across the globe. And friends, as you know, subspecialty practices become a little different ball game altogether. It's not like a general ophthalmologist. So we need to have a good idea about how, especially the newcomers who are going to set up the practice. So we have with us the expert panelists. We have Dr. Kumar, doctor, a good friend of mine, a senior refractive surgeon from Mumbai. Welcome, Kumar. We also have Dr. Anaga Herur. She's from Dombivli. She is also the West Zone ERC representative and the MOS Joint Secretary. She does a lot of refractive surgery. We also have two young Turks with us, Dr. Ritika Sachdev and Dr. Shreyas Ramamurthy. And of course, we have a dynamic moderator with us, Dr. Vardhaman Kankaria, who is from Pune, the Asian Eye Institute. Dr. Ritika is the daughter of a famous past president, Dr. Mahipal Sachdev, and Shreyas is the son of Dr. Ramamurthy and Dr. Chitra, the dynamic duo, past presidents, and now Dr. Chitra is, of course, chairman ARC. So we are going to have a very interesting session today. And to start with, a warm welcome to you, Rupal Madam. You have accepted my invite on one go. I'm so happy. And of course, the first of the subspecialty practice, we are starting with refractive. So a warm welcome. Once again, over to you, Vardhaman. And it's happy seeing everybody. Happy learning too.
Thank you very much, Dr. Taswala, sir. And again, my gratitude to you to invite me as a moderator for this session. Friends, we all know that the concept of refractive surgery has actually started almost a century back in about 1920s when Professor Sato performed the first posterior RK in patients who had keratoconus. And from that time to today's era, we have gone through many changes, including surface ablation, LASIK surgeries, femtolasic, SMILE, Contura, ICL procedures. And somebody who has actually seen this journey very closely that we are lucky to have today is Dr. Rupal ma'am. Dr. Rupal Shah ma'am, I'm going to give a very small introduction, although she doesn't need any introduction in India as well as abroad. Dr. Rupal ma'am is one of the pioneering refractive surgeons that we have in India for us. And she is what we call as the smiling lady in refractive subspecialty. She has been doing refractive surgery since 1994. She's the first person in the world to perform one incision SMILE procedure. She is also a pioneer and early investigator to develop the SMILE technology as such. She is also first person in the world, first surgeon in the world to use the Circle software for retreatment and enhancement in SMILE procedures. She is a very avid scientist. She has published a lot of literature, and she has trained almost 1,700 refractive surgeons who have come to her from globally from international refractive circles. And of course, she has many national, international awards to her credit. And one of the most important ones that she was invited faculty in the subspecialty course in the American Academy of Ophthalmology, ISRS, in 2020. She is a recipient of many prestigious awards and gold medals from IRSI, as well as many national and international organizations. And from Maharashtra Ophthalmological Society, ma'am, we welcome you to this subspecialty setup webinar on refractive surgery. And over to you now to give us your nuances and pearls about setting up refractive surgery practice. Over to you, ma'am.
Thank you, Vardhaman. Thanks for a very generous introduction. I will share my screen, and in the meantime also would like to thank the MOS as well as Dr. Jignesh Taswala for giving me this opportunity. I hope my slides are visible.
Yes, ma'am.
Yeah, very much, ma'am. Just put it on the slideshow mode.
Sure. I'm doing that.
Yeah.
So friends, I'm actually happy to see the interest in refractive surgery. As a subspecialty, it was always the last. I remember the times when we just started doing laser refractive surgery, and for all the conferences, there used to be only 10, 15 of us, but in some very small hall somewhere in the periphery. and we would be the only people listening to each other. From that to today, where it is becoming very quickly a very important subspecialty, is a journey which is worth pondering over. And thanks, Vardhman, I feel 100 years old because, as you said, I've like almost touched upon all the different types of refractive procedures which came into being and also getting practiced today. So I would just be happy to share my experience and how we set up subspecialty practice in refractive surgery and what could be there for the younger ophthalmologists. So when you're talking about the subspecialty of refractive surgery, you have to ask why, you have to ask when, and you have to ask how. So there are three questions that comes to any ophthalmologist's mind when they are considering refractive surgery as a subspecialty, and we should answer each one of these. So you should know that corneal lamellar refractive surgery never became integral to the general ophthalmics practice. And even today, it's a field that is admired or disputed from a distance by most ophthalmologists. Vast majority of ophthalmologists were unaware of the physiologic and engineering principles underlying the techniques. So it did take some time for refractive surgery to actually become mainstream. And always it's been taught that ametropic conditions are not diseases, but only variations of the normal. And ocular conditions are thought to be as black or white, never gray. So needing to wear glasses or dependence on glasses was never considered as a disease, but only variation of the normal. And this conservative approach was reinforced by everyone, our teachers, our colleagues, different associations. And hence, we all stuck to the norm that if it ain't broke, don't fix it. And that's something that all of us would like to believe. But the definition of broke itself needs to be redefined. And this is because it is coincidental with the phenomenal expansion of technology in medicine. So now no longer refractive surgery is confined to one single technique, which could or could not work, or sometimes caused more problems than not. Today, with the phenomenal increase and expansion of technology, it sometimes gives you even better quality and quantity of vision than ever possible with your glasses or contact lenses. And it's also coincidental with vastly changed priorities in healthcare. It's driven by patient demand. Patient wants to be without glasses. Patient wants to be having this freedom from dependence. It's also combined with dwindling physician's income from the most traditional procedures. So you do need to augment your practice, and you do need to add the refractive surgery as an armamentarium in your ophthalmic practice. Otherwise, you're missing out on a very big financial gain. And notwithstanding any personal or philosophical limitations, the modern ophthalmologist must be ready for corneal refractive surgery. So all of us should ask ourselves, as ophthalmologists, where am I in regard to corneal refractive surgery? So here there is a dilemma because patients have 6/6 vision to start with. They're typically younger, they are more educated, they are more internet savvy, they're more skeptical than the typical cataract patients. A typical cataract patient has no other alternative. And they also know that if there is a cataract, you need surgery. But a person who comes for refractive surgery does have alternatives. Also, the patients have very high expectations, even higher than what you can sometimes deliver. And therefore, if one is contemplating to be a refractive surgeon, it requires serious commitment. You cannot just do it as a pastime. Because if there is commitment, there are fascinating results. The vision recovery is really rapid. There is minimum use of post-operative medications, and patients are truly elated patients. You would not find happier patients than refractive patients in your a practice. So that gets us to the next question, that when should you be entering into this subspecialty? So you may be having an established anterior segment practice. Then you are ready to enter and add this as one more thing that you do in your practice. If you are a beginner, fresh into private practice, then this can help you again to start and do something more than what your neighbor probably would be doing. If you're working at an institution, it can be a great addition if you've learned corneal refractive surgery. And in all these scenarios, you need to put refractive surgery as a prime element in your practice. What you do, how much you invest will differ, but you should know that if you want to do corneal refractive surgery, you should do it well. And always explore the possibilities of not investing yourself right in the beginning. A typical refractive surgery practice will cost anywhere from 2 to 7 crores to set up, because you may not just need an excimer laser, but you need a microkeratome, which could be mechanical, it could be a femtosecond microkeratome. So femtosecond laser working only to make the flap. You need diagnostic equipments, and that's not just limited to a pachymeter or a topographer. Now you need a tomography possibility, that's the bare minimum. And then there is always a new blue-eyed boy around the block. So you do want to incorporate every little thing that can make your practice more efficient, more visible, and more safe. Plus, you may want to also invest in newer technologies like Contura or femtosecond laser for smile. So in the beginning, it's a good idea to explore whether you can use the laser belonging to someone else, or you can consider investing with other surgeons so that you are not putting all your eggs in one basket. You are also not getting totally bamboozled by the amount of money that you need to invest and the recurrent cost that it involves. But if you are confident of doing 50 or more eyes per month, then just go ahead and put your own centers. And if you already have a practice which is going on for a long time and you have a patient database, then it's not a bad idea to put it up in your own practice. And there are many different models of joint investments. Some models have worked out more than the other, and that would work on where you are, with whom are you trying to do, and it would also depend upon the level of and how comfortable or otherwise you are with other people. That gets us to the how we should go into corneal refractive surgery. So you need to drive patients to your practice. And this would be by two components. One is an external marketing. And external marketing today is not just confined to giving a newspaper ad saying now you have an excimer laser, but it has now many different and very effective forms of using websites, Google reviews, advertisements, and so on and so forth. I'm not really very good at this, and we have on our panel some very experienced and very people who have had success in doing external marketing to a great extent. And I think at the end of my talk, we would want to have their opinions and share their experiences. What I am probably learned over a period of more than 2 decades is something which is known as internal marketing, which would mean that how do you convince a patient once they're already in your clinic to go for laser refractive surgery. So the rest of the talk I've designed mainly to describe about this internal marketing. So when you have a patient, there is a battle. And the battle is to get the patient to do corneal refractive surgery. And it has 3 components. 1/3 of the battle has to be fought in your own mind. The other 1/3 is to be fought for the patient's mind. And finally, the third 1/3 is the battle that has to be fought in getting good results. And it's not just enough to get good results. It's also important for people to notice this good results. And let's consider each one of this in its total. So first of all, get confidence in the procedure and in yourself to be able to do that procedure well. And that can be done by reading a lot of literature, attending courses like this. You can visit different practices to see the best practice at each and every center. And initially, it's a good idea to practice under an experienced person. It's also a good idea to learn the procedure well. And what I would suggest is that initially you may not have a big volume. So keep practicing in your mind whenever you have the chance about the procedure, about the complications, about how if you get a free cap, what would you do? How would you recognize? How would you put it back? And not just once. Keep going through it again and again and again, all the steps of the procedure, how you would want to do, how you would want to counsel, how you would want to convince, what would be the decision? If this happens, what will I do? If that happens, what will I do? You should also keep practicing in your mind the consultation and the counseling. The counseling is really the key to getting a patient convinced that you should be undergoing a procedure. It's really a hard sell. And unless you have a flow, you would not be able to convince the patient. So it's very important that you keep practicing in your mind about all these. And then when you actually have a patient standing in front of you, you would be able to talk as if you've done thousands of cases. It's very important to be confident in your instruments, and just your own confidence does not work. So you should be knowing that and be confident that your excimer laser is well managed, it's well designed, it's giving good results, it's well maintained. You should have confidence in your microkeratome, that it's going to always give you good flaps. So invest in standard technology, don't try out new lasers, new microkeratomes, not in the initial stage at least, and in your technicians, because a lot is dependent on the technician. You are going to go in and be dependent on a lot of people around you who have done the autoclaving, who have made your trolley, who have fed in the data in your laser, who have assembled your microkeratome. You are sitting there and just doing that procedure. So you may be very good in doing the procedure, but if there is any small mistake, like we attended the conference the other day, and there was a case presented where the cylinder was at 172 degrees, and by mistake, it was fed in as 72 degrees. And you can imagine a significant cylinder of minus 3.5 diopters fed wrongly. So just one missing actually meant that the whole final outcome went for a toss. So you have to be confident that your people around you would have done a good job and that your machines are well managed. Because it's only once you are convinced that it's easier to convince the patient. And it just doesn't come out in the way you speak, but in many verbal and non-verbal clues that the patient can pick up. Even the stupidest patient would know whether you are confident about what you are saying. So when you tell them that, oh, it is safe, the weightage that you put on each and every word also gives up what you are trying to say when your words are not saying what you actually feel in your heart. Then the second battle is for the patient's mind. So a patient would need to be educated that there is a possibility to do a refractive surgery in him safely and effectively, predictability, and that the results are going to be good. You need to do a good counseling and a good consultation. So in terms of education, you can have several ways of educating a patient. So if somebody is already visiting your clinic, maybe it is your cataract patient's relative or the daughter who is wearing spectacles, then it should be that they should have an access to a brochure at least, or your assistant should be handing over to her a brochure saying you can get rid of glasses. Maybe a standee put there that if you're interested in getting rid of glasses, ask. okay, that it is possible to safely remove glasses. So you should have brochures, information, standees, posters in easily reachable and visible places, and not like somewhere in the corner in one drawer, and not having a person sitting there who is guarding it with her lives and is so reluctant to give a brochure as if she is handing over her trousseau to you. So it's very important that I've seen in practices, the receptionist sits at the desk, and if somebody asks for a brochure, they say, okay, read and give it to me back. Or sometimes you find that when I've also seen when I walk on outside the corridor in my hospital, there are like my brochures which are in the dustbin or just lying on the floor. It hurts you, it breaks your heart. But you should know that brochures do not cost much. So encourage patients to take brochures. Even out of 100 brochures that gets distributed, even if it means that 10 people get interested and 1 gets converted for a surgery, it's still going to cover more than the cost of that brochure. So let the patient be educated. Also, it's important to prominently display your credentials. If you've learned LASIK somewhere, if you have treated some celebrities, if there are people who have given you some nice comments after their surgery, put it up in your clinic so that the patient also knows that they've come to the right place. They are very reluctant to ask you. I know of a patient who last year asked me, so doctor, how many procedures you must have done? And she was so reluctant to ask me, and I was so reluctant to answer her. And what do I tell her? Like, enough so that I can operate on your eye. So it is very difficult. We are very modest people. We cannot say that, oh, I've done lights, what are you asking? We are not going to be able to do that. So it's better that they find out from outside itself that this is the person who has enough experience so that I can trust my eyes with them. That this person is well qualified to do this procedure on my eyes. That much is enough. I know that it is, some of you may feel that, oh, it is like display of, and it's, why should you be showing off and all? But you imagine, you put yourself in the patient's position. You may feel that you are very well known. The patient may not have known you that well. And patient does want to know whether he's come to the correct place. So it is important that they get this reinforcement that they have come to a qualified person who knows their job. So you can have various forms of display. You can also have other devices to create interest in refractive surgery. For example, newspaper clippings, patient testimonials, posters in your clinic, videotapes. You have seen in many clinics that there are monitors, and what is getting played there? Some Saas Bahu serial that the receptionist likes to watch, or some songs playing there, or something which is like of some news which are of no use to you. This is a captive audience. What you should be doing instead is to give idea about what refractive surgery has reached, what sort of procedures are getting done all over the world. What have you done as a procedures? How you can put up so many things which are educational about the refractive surgery. And you should have a couple of different types of tapes playing, because you know that our patients wait in the waiting area for sometimes even a couple of hours. So if you keep playing the same tape again and again, I know some people have come and complained to me that, doctor, I have come for the 5th time and now I'm really tired of watching this particular tape. Can we change it? So it's important that you are changing the tapes. You are also making it more interesting and putting in newer things and generating more interest about refractive surgery. Then it comes to the staff. It's important to employ correct type of people. You should educate the staff to answer questions. In fact, you should encourage staff to spend time to talk to the patients and address their concerns and empathize with them. Because there are certain things that the patient is not willing to share with the doctors. So if they want to take a drink on the day of the surgery, they're reluctant to ask you that whether I can smoke, whether I can drink, whether I can have sex. but they would be able to talk to the staff about these concerns and they can ask. But it's important that you are educating your staff to give the correct answers. And there are predictable questions. And staff can actually go and talk to the patient and say, oh, okay, you are feeling little gritty sensation. It may worsen for the next couple of hours, but then you will be fine, don't worry. So if your staff knows, then they can go give that information and they can talk to the patient and put them also at ease. In a general practice, train the staff to recognize the potential refractive surgery patients. So as I told you, if the cataract patient has come with a daughter wearing glasses, the staff can on her own volition go and give a brochure that, why don't you go through this? Maybe it will help you. And most important, encourage your staff to undergo the procedure themselves. So if you're a refractive surgery clinic and if your receptionist is wearing high myopic correction and sitting at the desk, the patient is always going to first of all ask you, if you are wearing or your staff is wearing, that why are they not getting it done? And it's really putting you in a defensive position. So if you can, please encourage the staff to do. In the initial stages, we used to treat our staff totally free of charge. And then we found that 1 or 2 joined us simply to get the refractive surgery done and then leave us after 6 months or so. So now it's a rule that they should be employed with us at least for a year before they are entitled for a free refractive surgery. So that's, of course, a corollary to this, but it's important because then they can say that, oh, why are you afraid? I've got it done and it's been 5 years. So that really helps for the patient to decide about corneal refractive surgery. And a word of advice, don't treat a refractive surgery consult like a routine consult. People want to know everything that they know from their Google tutor and more. So they expect that you would know at least as much as the Google knows, and you would be able to even give them even more information. So take time to explain the following. You explain to them the procedure that you have chosen for them or that they ought to be undergoing, or give them all the options that are there. You should give prognosis based on individual case and not just play a recorded version of what you would have in your clinic. That, okay, you sit here, go through this is how it is, because it's not personalized. And patient would not feel as if you have given it a thought about their eyes and then giving the answers to their queries. Also answer all the queries that the patient may have without losing patience, because they have a lot of queries, believe me. Also, it's a good idea to show that you are concerned about how safe is the procedure. And this comes if you can answer these questions before they are asked. And there are standard questions that most people have concerns about. Whether the surgery is safe, whether it's going to be effective, whether the number comes back, how many days they need to be off their work, how much it's going to pain during the procedure, after the procedure, what restrictions they need to observe. So if you can answer all these questions without getting answered, then the person knows that you are concerned and that you would be the correct person to go and do refractive surgery. And then, of course, after all this, the patient gets convinced. The most important part is to get good results. So make sure that you get good results by learning the procedures properly and also doing them, performing them well. And then once the patient is happy, put a testimonial book, get post-op patients to give their phone numbers if somebody wants to talk to them. Do things to encourage patients' loyalty. So you could, in fact, call them, maybe have an annual get-together, so that it reinforces everybody in everybody's mind that, okay, it's a good procedure and we're all happy. And I would like to leave you with this note that refractive surgery is a subspecialty which has come of age. We have wonderful procedures and results are excellent for more than 98% of well-chosen, well-done patients. So it is something that we all must incorporate in our practice. It's not enough to say today that it is still new and then I would like to wait, I would not want to work on a normal eye. That doesn't hold true. Now there are millions of patients who've got this one or the other procedures done and they are happily moving around. And now it's also having a track record of years of practice. So it is important that you are trying to incorporate it in some or the other way into your practice. Thank you.
Fantastic, madam. Rupal, madam, I think it's a master class, not only for the refractive surgeon, it's for all subspecialties what you have covered, more so for the refractive practice. Very important tips and good pearls of wisdom you have given, and we are truly enriched with your talk. We'll have a panel discussion. Over to you, Vartaman. Unmute yourself. Unmute.
Thank you, sir. And thank you so much, Dr. Rupal ma'am. It is such a pleasure always to listen to you, to learn from you, from your very, very huge experience, not only in number of years, as you said, but also the amount of variety of procedures that you have done. And you are the best person to talk about setting up the refractive practice. And as we have correctly said, now we have ventured into from ever evolving or debatable controversial subject to a well-formed subspecialty in ophthalmology today. And many people want to venture into refractive surgery because of the success that has been shown by pioneers like you. And of course, it does require a lot of grit, dedication, learning, team building, understanding of finances, marketing. But at the end, it is a very, very fulfilling subspecialty. And most importantly, it does require embodying and adapting to the vision correction mindset, as you have said. So from now, so I'm going to have a small panel discussion with our amazing panel. And we are very, very lucky to have a great balance of uh, very, very experienced surgeons at the same time, very specialized but younger, and who are currently doing a very high volume refractive surgery as well. And these are very dedicated refractive surgeons. They are known for both science and also for success in the practice of refractive surgery. So I'm going to basically have a small introduction of our esteemed panel. So to begin with, we have Dr. Kumar, doctor. Of course, Dr. Kumar doesn't need an introduction as well. He is a very, very prolific anterior segment surgeon who specializes in cataract surgeries and laser refractive surgeries. He has had great success both academically as well as in terms of his practice. He has presented and won awards for both best papers as well as best videos, and many international conferences such as ASCRS, APAO, uh, APACRS, and of course he was recently awarded by ASCRS as the best film award for in-house production. He has also received many national awards, including the Jit Singh Gold Medal by the Chief Minister of Maharashtra, Best Academic Private Practitioner Award, and the Best Video Award from our own Maharashtra Ophthalmological Society during its Silver Jubilee Conference. And he has contributed many chapters in textbooks. And he is also known as the first surgeon in the world to perform a Presbyer LASIK by Schwend on a presbyopic patient. So welcome, Dr. Kumar, for this panel discussion.
Thank you.
Next, we have Dr. Anagha Herur. Dr. Anagha, as we know, is currently the Joint Secretary of Maharashtra Ophthalmological Society. She is member of ARC West Zone in All India Ophthalmological Society. She is Medical Director of Anilai Hospital, which is a very high volume cataract and refractive surgery center based out of Dombivli. And she is again very prolific cataract refractive surgeons, has made many national presentations and have many awards to her credit, including gold medal from IRSI. Now we come to two of my very good friends, Dr. Ritika. Dr. Ritika is director of Center of Sight. She's trained in MAMC and she was trained in cornea and refractive subspecialty at the prestigious RPC Center at AIMS. She's a recipient of IRSI Gold Medal, Dr. Daljit Singh Gold Medal by IRSI. She is also recipient of UKSOS Gold Medal, Krishna Sohan Trophy from DOS, and Iskaras Young Achievers Award. Welcome, Ritika, to this panel discussion. And of course, now we have with us Shreyas Ramurthy. Shreyas is a great cornea and refractive surgeon. He has been trained at the prestigious LV Prasad Eye Institute for his cornea subspecialty. He is a dedicated cornea, ocular surface, and refractive surgeon. He is currently the director of the refractive services at the Eye Foundation in Coimbatore. He has had 8 Best Paper awards from many national and international conferences. He is also a recipient of gold medal by IRSI. And I think He is currently head spearing a lot of expansion for I Foundation, like Ritika, she's doing for CFS. So welcome all of you to this panel discussion of how to set up a refractive practice. I'm going to ask a few questions, and I do expect to have answers from all of you. And we are great, and we are very lucky to have refractive surgeons of different experiences and seniority. So first thing is, I would like to know, we have known from Dr. Rupal ma'am, but I would like to know from the other esteemed panelists. Please tell us about, in short, about your refractive surgery journey. When did you start? How did you begin? And how have you grown? So maybe we can start with Dr. Kumar, and then we can go on.
So my first case was incidentally done in Mumbai at Rupal Center. It was called Razor Vision Center, if I'm right. It was in 1995. And that was a surface treatment which I did, which developed an opacity. Unfortunately, Rupal also followed up the patient. I also followed up the patient. And it has everything to do with, I think, the contact lens that was put later. I don't know whether Rupal remembers this.
Of course, I remember. But it was a series of it.
Yeah, so it was in 1995.
Yes.
I bought my own laser in 1999, so there was a 4-year gap. Who has taught me LASIK surgery was Dr. Bharti and Dr. Vivek Pal, because I always believed in the Moria microkeratome, and that time Bosch and Lomb was really selling like hotcakes. So everybody bought Hansatome, and I wanted Moria, and the waiting period for Moria was 4 months. So I am actually always grateful to Dr. Bharti and Dr. Vivek Pal, who flew down every alternate Sunday, and I had a Mel 70, so I bought the Mel 70 from Rupal's husband because he was the distributor for Asculab, which ultimately got bought by Zeiss. So we were the first Gaussian beam Mel 70 in India. And after me, the Daljit Singh and Haradya and everybody bought it. So I'm anyway connected to Rupal, who's always been teaching me refractive surgery at the same time since 95. So this was my journey, but then of course went to Schwind and always been a Schwind user ever since. And now I've got Clear, which is from Z8. Rupal has got Zeiss, and there are many machines coming into the market. But I think statistically, my future thinking is that Surface, femtolasic, and Smile will remain there forever. Recently, I don't know, Rupal, you didn't mention one thing in your talk. What we can't all predict, your talk was excellent, is the gas price for a gas cylinder.
Yes.
From 7 lakhs has become 14 lakhs. Now,
and it's in short supply, so
correct.
it's not coming in time.
It was one of my panel questions.
So this is what we don't look at, and this is what we have to think of. This is what we have to calculate, and it changes all dynamics of calculations.
You're right. You're right. Absolutely. Absolutely. Great. So,
Great.
Dr.
I
Anaga.
purposely didn't touch upon the financial aspect because I think that we have on our panel really people who have much more experience in calculating it today.
True.
Yeah.
Yes, Dr.
Anaga.
Yes, hi everyone. And first of all, Rupal ma'am, lovely lecture and really impressed totally. So actually, she is also my guru for LASIK, and I completed my MF in 97 and I started LASIK in 97 initially. And for a few years, I was doing at some other doctor's place, like how ma'am said. And then in 2010, I bought my own LASIK. And Rupal ma'am has actually taught me all the small nitty-gritties of LASIK, and I would always be indebted to her. What she said was so right, that you need to first see what is your volume of practice, how much you are able to generate on your own. And yes, you need to have deep pockets for that. So initially, I first judged as to whether I would be able to sustain it or not. And I would say even today, not today, but in the beginning at least, most of your cataract practice always helps to compensate before you actually break even. And then a few years down the line, I bought a femtosecond laser. So I'm using the intra-laser system for bladeless LASIK also. And today we have more than 70% of our patients with bladeless LASIK, and others I'm using the MEL 80 system. and maybe I would need to update it next year. And I'm also using the US, the 1 use plus SBK microkeratome. So
Great.
it's
Thank
been a
you.
lovely journey.
Great.
Yes.
Super. Yes. Over to you, Ritika. Now, Ritika and Shreyas both are second generation refractive surgeons. So this is because both their parents have been one of the pioneering surgeons that we have in India. So over to you, Ritika.
So I actually got exposed to refractive surgery at AIMS, and the retina department swore against refractive surgery. So if you send any patient to the retina department, they would counsel the patient that it is the most unnatural procedure to get done on your eyes. So there and then, because there was a time when there was a large majority which was speaking against refractive surgery, and that was during our senior residency time. Of course, when I joined Center for Sight, we started our journey with the intralays. And after that, we were fortunate enough, because I think of a large influence from Dr. Rupal, to move over to Smile. It gave us a competitive advantage because we were one of the first few centers to adopt Smile. So the journey became very significantly, we got a significant limelight because of the technology. And we obviously, Dr. Mahipal had an individual brand that he had established. However, sometimes you should not get too complacent. So the Contura marketing wave really became very big. And that really showed that as a cataract surgeon, sometimes you look at the overall picture, and that is a mistake. You have to dissect it product wise and specialize in it product wise. So with that in mind, we now actually, I stuck my neck out and I said, we need a Contura also. So now we have Contura and Smile both under one roof in Delhi. Of course, we have access to I personally have access to the intralays of Visumax. And we are fortunate to be doing a trial with J&J for their version of the lenticule extraction. And it's heartening to see that multiple platforms for that may be available in future and will help progress that journey. Our journey has really been to magnify and amplify the practice as a specialized vertical beyond cataract and beyond an individual. Because an individual is able to give the experience, but to depersonalize it and give the experience as an institute, only then you can basically grow. So that is the journey that we are on. And we've just launched a sub-brand about 6 weeks ago called Planet LASIK to that effect, just to create a resonance with the staff, with the team, with the patient, that it is a different experience, a different target audience that you're speaking to and that you're treating. So just to create that differentiation is what we've started the journey on.
Fabulous.
Amazing, amazing. I think CFS journey is quite an inspiration for everybody. The way, as you have said, to depersonalize the process and make it into an institution, and the way that you have grown. So kudos to Dr. Mahipal sir and you and your team, Ritika. Yes, over to you, Shreyas.
Thank you, Vardhaman. And at the outset, thank MOS and Taswala sir for having me over at this webinar. And Rupal madam, always a pleasure hearing you, and always wonderful to hear you and learn from you. Much like Ritika, my experience also started during fellowship. I did my first LASIK 10 years ago in LV Prasad. And it was a time when Smile had just come in 2012 and this thing, and people were still learning and adapting to it. It was an exciting time to be getting exposed to refractive surgery. But I think one thing which was very important is my approach to refractive surgery didn't come as a cataract surgeon converting to refractive surgery, but came as a cornea person who basically was doing cornea surgery. And refractive surgery was something along the side, not something which we were there to learn as such. And that really, in a way, actually, I would say had a positive impact, because we were very literature oriented, study oriented, what we wanted in terms of results, in terms of analyzing critical appraisal of literature. And from that background, when you move on to refractive surgery, it's a completely different practice, but it kind of gives you the strength and a depth of understanding from moving from a cornea surgeon to being a refractive surgeon. and the way you approach the entire field is a little different. And that's where Madam touched upon the fact that read as much literature as possible so that you're armed with the knowledge and the confidence to take forward, to set foot in the refractive journey. And frankly, that kind of sets each person apart from your peers, because the only thing everybody, even the most basic cataract surgeon will be able to deliver excellent results from refractive surgery. The only way I think we'll be able to differentiate ourselves is by giving a certain extra, sharing a certain extra knowledge or certain extra information to the patient, which a routine surgeon may not be able to do. And I think that's one thing which I owe to LVP for that. And subsequently, of course, I mean, I entered a practice where my parents had a fairly large refractive practice. But I think where we grew from then, and I think Ritika also touched upon this, is growing from an individual into an organization. So rather than patients coming in for, let's say, a Dr. Ramurthy or a Dr. Chitra, it was making the transformation about making the patients come to Eye Foundation as such. And I think that was the challenge. And I think that's what we are most proud of now, that I would say less than 5% of our patients come asking for them. And it's not just in Coimbatore, but across our 15 centers, most of which have a refractive surgery practice. And because of the number of different centers, we've also had the good fortune of being exposed to different platforms in femtosecond, from Visumax to Lensex to Intralace to FS200. Similarly, in the Excimer, from Alcon EX500s to Schwind to this thing. So that kind of gives you, the choice between the different machines, understanding of each machine, how it works and other things. And it's been a privilege to be able to get an exposure to that. The remainder part of the journey, or the last, I think, few years, has been really focused on making each of these equipment self-sufficient. And while some have been a runaway success, and some have been still a process in learning, one thing I would always feel is that in each of these centers, even where the refractive practice may not be doing exceedingly well, it has still made a difference to the overall practice as such. In the sense that just because you have a top-end machine or an advanced machine or advanced laser available at that particular city, where you are a newcomer and you don't have an established presence in that particular place. And this applies to any new surgeon in a particular place thinking of refractive surgery. By bringing in the refractive practice and marketing the refractive practice, it's not just the refractive practice that grows, but definitely your cataract, your retina, all patients, even the general patients walking in, they feel that, yes, if this practice has the advanced equipment, they are likely to handle the basic problems also quite well. I think that's something which has worked. And definitely, I mean, as Ritika also touched upon, marketing it both digitally on other platforms as well as on satellite platforms has definitely helped. It's not just helped in the newer centers, but in the growth of the existing and the older centers as well. While word of mouth is definitely the most important, and internal branding, like what Madam spoke about, and internally talking to your own patient base is definitely the most important to set up. But what I've learned in the last few years is that it's not just the older centers, I mean, just the newer centers which require marketing, but even the older centers. And the older centers actually grow even faster with marketing than the newer centers.
Fantastic input. Huh? Yes.
Thank you, Shreyas. And I've seen the way your presence had made a difference in the Eye Foundation group, and definitely kudos to you. And of course, both Dr. Chitra ma'am and Dr. Ramurthy sir is a great inspiration for all of us. So now the next question is, what are the current avenues that are there today to learn refractive surgery subspecialty as such? So I think we'll start with Dr. Rupal ma'am.
So today, of course, with COVID, we have all learned that it's possible to be learning online. So that has become the biggest avenue, because all the webinars, all the courses, everything has got now place on the YouTube. So it's available to everybody to use, which was not possible before because you remember, Vatman, how many conferences we used to attend?
Yeah.
I mean, every year, I think at least 10 or 12 conferences in India or abroad, and plus all the small meetings that we were going to. And that itself was pretty taxing in a way. And it was also a lot of time spent. Instead of that, now we have all the big people, stocks and everything at your disposal whenever and wherever you want to approach it. There are also lots of teaching courses. So in India and abroad, which you can go and approach. If you you can also go visit practices in India and abroad, where you can observe good practices. And there are LASIK courses that are available, like the ones that we conduct and so many other people do, where people actually teach you and handhold you to get into learning your first LASIK. So I think that is all helping a person to now get into refractive practice in a much safer way than just jumping into it. Also, there are now in all cities centers which are open for other people to come and use, which was not there before, and not the smaller places. At least now it's there everywhere. So you can be a part of a group practice either as an outsider or as a core group. And you can, even if you have only say 5 patients in a month, you can still go ahead and start under guidance of people who are more experienced, and then slowly build your practice up in the correct way. So today, refractive practice has become pretty easy for somebody to have at entry level. Whether to make it a success would be whether you are interested in making it a success and how much you are willing to pay as in terms of the effort and the time and the commitment is what is going to make you either successful or not.
Absolutely. Thank you, ma'am. I think it was very good. Of course, for everybody's knowledge, ma'am conducts for so many years refractive courses, and many people from all over India and abroad, as we have seen already, they have got trained by ma'am. Many
So
of them are
74th course in this September.
Amazing, ma'am. So, Shreyas, would you believe that if somebody wants to start refractive surgery, is the phakic lens probably one of the simplest way that they can start to have that mindset of refractive procedure, then move on to surface ablation, PR, LASIK, and so on and so forth?
I mean, if you have PRK and mitomycin C and you have phakic IOL, pretty much you don't require anything else. You don't even require a topography, because frankly, with your refraction, if you go ahead with the surgery, you will. I mean, it's an oversimplification, but then you will be right 99.99% of the time.
Yeah.
So there's really, it's a little left to imagination, understanding, and other things. Because it's actually that easy. But having said that, I would say for anybody wanting to go into refractive surgery and do it, especially in a younger age group, I would say investing time to do a proper fellowship is definitely useful. Although it can be learnt in 10 days time, really. I mean, there's no, the surgical skill can be picked up in 10 days time, but the overall exposure, the practice, the seeing the variety of cases, as well as the difficult ones, the simpler ones, the complications, and the way each of these different scenarios are managed, definitely go a long way in giving the confidence in tackling the wide variety of patients in your own clinical practice. So I think gone are the days when people were assuming that a fellowship for this is not required. So maybe it's a redundant point right now, but definitely investing time, whether it's 6 months or 1 year, to do a good fellowship for refractive surgery is definitely very useful.
I think it is a very valid point, and I truly echo your sentiments. I personally did 3 long-term fellowships when everybody was telling me, why are you spending so much time here and there? But definitely, I think for personally, it has helped me, as you have correctly said. And ma'am has also said that if you want to have a refractive specialty as a subset of your practice versus if you want to become an end-to-end refractive surgeon, what is your goal? So if your goal is to become end-to-end refractive surgeon, as you said, definitely having to get that mindset, complication management, to have those nuances, it is important to spend time with the right mentor and take it from there. Absolutely. I think I completely agree with you. So, Ritika, so if there is a mid-career comprehensive ophthalmologist that you're looking at, somebody who is at 40, 45, who is doing a very good volume cataract surgeries, when do you feel that when is the right time for such a comprehensive ophthalmologist to start refractive subspecialty practice? And also, when is the right time to start his own center of refractive surgery?
So I think Dr. Rupal ma'am has pointed out there is a critical volume that you have to reach, which basically makes you be able to maintain the machine, because not only do you have to buy the machine, there are AMC and other costs that have to be carried along. So there is a critical volume. So for that, you have to see the kind of OPD that you're seeing, the paying capacity of the OPD. And overall, I do feel that refractive surgery requires a particular persona. You may have, in certain organizations, high volume cataract surgeons who don't communicate well to the patient. So there is a persona that certain surgeons do have, which lends themselves better to refractive surgery. If they don't have that, they need to inculcate that. Because refractive surgery, half the battle, like ma'am said, is in the mind of the patient, which a surgeon wins by their confidence in communication. So if the surgeon has a mindset, the volume, they should definitely take a leap. We've had an experience of, I think, more than 20 LASIK installations. We've had high volume cataract surgeons do single digit refractive surgery also. That is because they don't have a focus on refractive surgery.
15 minutes, 15 minutes.
It's just part of, it's just filling up a room and it's completing their practice. That will not succeed. You have to devote developing yourself as a counselor, developing yourself as a surgeon, and developing a team, and also developing the mindset of keeping a scorecard, because this is what I need to achieve. It's not about targets. It's simply about evaluating your growth. Obviously, if you're creating happier patients, those patients will get more patients. And it is a vicious circle. The more happy patients you get, you actually become confident as a refractive surgeon that this is, Dr. Ma'am keeps telling me that, just lie down in Vadodara, I'll do your smile. But every time I see a patient of refractive surgery I've done, and they come to me and say, it's changed my life, I am, it just gives you the conviction. Sure. So I think that volume, if you don't get the volume and it's just a trickle effect, right, it doesn't. You have to push yourself mentally, financially, in every which way. Otherwise, you can't dip your feet. You have to be in the water and learn how to swim.
So would you also believe that minimum, let's say, viable volume is 50 eyes per month, like Dr. Rupal ma'am said?
It depends on your ticket size also and the machine that you're investing in, because there are a lot of centers, particularly in Gujarat, who are doing very low cost LASIK surgery. Absolutely. So you have to look at the cost and the margins, and therefore define, and the deal that you're getting from the company, and define the practice. And there are a lot of practices I have seen, high volume cataract practices, simply by giving a counseling to the attendants, they are able to generate 10 to 20 LASIKs just from the attendants. So of course, direct marketing and all is an additional investment, but you have to look at the volume of patients coming into your center and the volume depending on your price points. Perfect. That you can generate.
Perfect. Super.
Also, you have to account for the upgradation of your equipment.
Yeah.
So it's not just enough to sustain whatever you have spent. You have to also be able to gather for the subsequent upgradations that happen.
True.
You have to keep investing more and more.
Right.
It's not like a cataract that, once you have a good microscope and a good phaco machine, usually you can pull on for like quite a few years. And you can still do well just by maintaining those tools. Here, it's a much more expensive affair.
Right.
So what would you believe, ma'am, is the cycle time for examiner, for example?
Ritika would know.
Examiners last for a very long time, but we've had the good fortune of being able to send it to a tier 2 city. So it depends on the city where you're in. Metro city, the equipment goes into so-called obsolescence quicker. For example, I had a MEL 90 and we wanted a Contura. So if there was no point keeping a MEL 90 and a Contura, we shifted the MEL 90 to another center.
Right.
So, but that said, we've made Dr. Mahipal is actually, I think, great respect to the equipment has come from his teaching us, and he's made his original microkeratome from the 1990s, still last.
Wow.
And the same with Dr. Rupal ma'am. So
Amazing.
I think the respect for the equipment makes it carry on for more than a decade, easily.
Great.
Quite
I think
right.
You can ask Kumar also that because he's into private
So,
practice.
yeah. So, Dr. Kumar, I have a important question for you. Are you there online?
Kumar is gone for dinner.
Okay. So I think
He's
Dr.
there
Anaga,
very much.
Dr. Anaga, maybe I can ask you this question. So
Yeah,
what do
hi.
you think
Yeah.
are the common mistakes in the beginning of setting up of refractive practices that people make?
That's a lovely question, actually. So I think most importantly, you need to plan that project. It's not something like, you just go and buy a microscope or you just go and buy routine piece of equipment. This is something which you need to plan. You need to sit down with your CA, you need to sit down and see what would be your projections. You need to know each and everything so that you don't fall flat on your face. You need to have your projections, you need to know how much you will be able to generate, and figure in your mind as to, yes, in 2 years or 3 years or 5 years, you would achieve break even. That's number one. Number two is not learning the right technique. If you're not trained well in it, if you're not able to deliver what the patients really want and get good results, because you may have a lot of money, you buy a femto, you buy a smile, but if your results are not good, at the end of the day, patients are not going to come. In fact, it is going to be negative publicity. So your cataract patients also will, be somewhere, the word will spread around. So that will be affected. And number three is not being able to handle complications. Even if you are a trained person and your complication rate is, everybody does have complications. Nobody will be without, but you should be able to manage it. So a patient who comes to you would say, what if, like you tell them, okay, you may have XYZ. So what if I have a complication? What will happen? Will I lose my eye? So you need to have that conviction in yourself that yes, no matter what, I would be able to manage in whatever best way I can to give to the patient. And the fourth thing is, if you're not a very good communicator, that holds good for every type of, in like whether it is cataract surgery or any other surgery also, but more so with refractive surgery, you should have that ability to communicate well to the patient that yes, you are coming to me for something that you want more. You are already a normal person. You're not coming to me for a problem. You're coming to me to change your life. So that communication and that skill has to be there in you. So if you are not very good at that, if you are somebody who is like a chalta hai attitude and no, I just want to do this and go back, then maybe you need to think twice.
Vardhaman, you're muted.
Right. Sorry. So refractive surgery is like a package. You have to be good in your science, art, and commerce of refractive surgery to be successful, as you have said. Many important points that you have brought forth. So, Dr. Kumar, yeah, so I think this question also was for you. That what do you think are the common mistakes that the people actually have typically when they begin off by setting up their refractive surgery? What are the common mistakes that they make?
See, there were some centers in the 99s and 2000s which started and then shut off. So why they shut off was because maybe buying the wrong technology, okay, investing in the wrong. So today when I have to buy something, people may not look at it because some of them are loaded, some of them don't need to worry. But I look at it like if you need air conditioning 24 hours, if you need dehumidifier 24 hours, I will look at this. It may cost you 10,000 rupees a month, but if you keep the same laser for 10 years or 7 years or 5 years, it costs a lot of money. So buying technology, understanding technology, and then utilizing it to the best of giving your results is also one step I think the youngsters should learn. So we all know that all lasers, do you have an Audi, you have a BMW, you have a Mercedes, all have 4 wheels and a steering wheel with air conditioning will take you from place to place. So most of the lasers do what they're supposed to meant to be doing. But in today's world, you have technology which is so sensitive to temperature. If you open the OT door twice and it says temperature change, kindly reboot, and it reboots and then it shuts down for 15 minutes. So this is what I think everyone should understand before they get invested into technology. And one more thing I want to tell you, that today's world of youngsters, everyone is extremely aggressive. So I knew, I met Kamal once in a meeting where at 12 o'clock in the night, he had 1,200 posts on his G reviews, Google reviews, which brought his rating down to a half a star. So there are people employing people, okay? There are eye doctors employing digital people to make sure that the competitors are pulled down. You'll be surprised, Vardhaman. 2 days back on my website, address is changed. And it took my clinic from Andheri to Borivali.
Wow.
And email is not known to everybody, means the web number is not known to everybody, but email is known, but the password is not known to everybody. And I had to struggle with Google to change that back. And I got calls from patients and reviews that you started a new clinic in Borivali. I said, no. And this I came to. So this is very common that youngsters will be very excited to start new things. They'll have all the things, but they have to keep a watch.
Right.
And financially, of course, as what Dr. Rupal said, your investment is from 2 crores to 7 crores. But if you buy the Zeiss Pro itself is 6 crores.
Yeah.
So the investment is more than 10 to 12 crores now. If you buy M39, so only Center for Sight, Ramamurthy, and Rupal can afford all this. So we are the outsiders, which we have to be worried about. But if we all unite, and there are neutral centers which have started, which in Bombay, I think Rupal knows there are a lot of neutral centers, which is a successful formula. It's not that it's failing; it works quite well.
So that brings us to the next topic of finances. So basically now whenever you want to invest in refractive surgery, if you want to do your own setup, now the companies bring forth options of leasing by them versus there is something called as a interest-free delayed payment versus taking loan from the bank versus doing bundling. So I think we have everybody is now well versed with finances, and especially I think 2 financial gurus that we have, Kritika and Shreyas, and also Dr. Kumar can probably tell us more about, for people, what is the road forward, what are the pros and cons of each. So I think we'll begin with Shreyas. Yeah.
Shreyas. So I think there are a lot of interesting and exciting options available now. And I think for anyone who has a good cataract practice, when you start working out all these critical numbers and other things, it's all fine. I mean, it's on paper, you can work it out. But at the end of the day, like I was mentioning earlier also, it's about the value it adds to your overall practice. So let's say if your volumes, numbers, revenue has been, let's say, growing 10%, 12% a year on year, after adding your refractive practice, what is it that it grows by is another very important parameter that you need to look into. And that is something which has added to each of our practices, where we didn't have a particular machine, we added it, or added a newer technology, added a femtosecond laser, or added this thing. That center, not just in the refractive surgery alone, but in all other segments, the rate of growth, year-on-year growth has increased. So that is where, in 5 years, 7 years, your break even for the machine, for the including cost of consumables, etc., definitely comes into play. So I think that is another criteria that you should take into account. The fact that it will accelerate the growth of the rest of your practice also when you're adding refractive surgery or adding a very important dimension to your practice. The second thing, definitely bundling options are excellent. If you're already a good, a cataract surgeon with decent volumes, I think you can really drive to bring down the initial cost of the laser. The initial down payment which you do can actually be minimized to a very small amount. And your cataract numbers and volumes which you're already using with the bundling will definitely help, and that kind of reduces your burden. And definitely that's the only driving force for us, and I'm sure for CFS as well, where we are able to open multiple machines. It would definitely not be possible if we thought that each of those machines have to sustain themselves with their own laser practice and then go forward and then start the next machine. It would definitely take ages. So it's definitely the existing cataract numbers, volumes, the bundling deals which are going forward. And I think even for an individual practice with a decent cataract numbers, it is possible to get an excellent IOL bundling done, which can definitely go forward. Initially, I don't know whether I should be saying all this, but definitely driving a hard bargain in the beginning is very, very important. Whether it is your number of years of CMC warranty that you're taking upfront, the number of gas cylinders commitment that you're taking upfront, all this is very, very important. It does seem that why not, the company will offer you 2 years, why push them for 5 years? You're looking at what your initial cost is. But that 5 years is what is really helping you to increase your profitability in the 4th and 5th year, because your first 2 or 3 years you're spending on just paying back for the machine, the cost of the machine, and getting in that additional years of warranty really helps you to carry forward. So just warranty is just an example, but any freebies that you can get thrown in, driving down the cost of a microkeratome, driving down the cost of your topographer, putting it all, bundling it with your machine. When you buy a new machine, get your previous phaco CMC, your other microscope CMC also bundled into it. Get your previous equipment. If I'm buying a catalyst, the previous intralace machine CMCs get bundled into the catalyst. These are all innumerable advantages that you need to push, because these are hidden costs, and these hidden costs definitely add to the overall costs and volumes. And definitely it's important that you sit down at the table and factor in all these points with the companies before you go ahead and make the decision for the machines.
Super. Great pulse, Shreyas. I think cross bundling, and I think it is a very smart use of bundling, as you have said correctly, and not looking at the initial price, but looking at the longevity of CMCs and other things is something that all the initial refractive surgeons will definitely look at. Dr. Kumar, from your pulse of finances.
I'm not too much in favor of bundling. Even though if you have a high volume practice, 2 reasons. One is you're paying 5 times, 4 times, 6 times the value of the real product. Even though if you're using it, it is, I think, more beneficial to the company than it is beneficial to doctors. I'm not sure. I'm not that great a calculator, but psychologically it feels that I think their percentage in profitability of multiplying by 6 is far higher than leasing the company machine out. So if a company, and taking a loan in today's world, I'm not too much in favor of. There are some companies in exam laser who give you per case basis. So that's one option. You can work out with them if you want. But I personally am of the belief of a lease. So some companies do lease out machines, and leasing is better financially to some extent, because the lease amount is a complete write-off in taxation. So if you are leasing out, say, 1 crore, and your taxation is company taxation today is 22%, then you have actually saved 22% of tax is what it would apply. So the lease amount is a complete write-off. Another big advantage is like a deferred payment. So you're earning and you're paying, you're earning and paying. See, whatever said and done, finances will have to be calculated. If you're buying your own machine, you have to have X number, like what Dr. Rupal said, per month. If you are not having that, it's going to come on your head. And then you're putting your cataract money into your refractive money. And that's not what it should be.
Right. Absolutely. I think.
Sorry, sir. Sorry to interrupt. My only counter is, when people say we need to have that 50 or 60 in mind, you never know until you start your practice that whether you're going to have 50 or 60. So for a person who's starting off and wanting to invest in an excimer machine, getting that number or saying that I have the confidence to build that number is a challenge in itself. So that's the reason why I'm saying that it helps your overall practice and helps the overall growth of the center, primarily because even if you're not able to reach that 50, 60 in the first month or second month or third month, don't fret. It will definitely happen over a period of time, because refractive surgery, even more than cataract surgery is also dependent on word of mouth after a certain point of time, and the numbers do grow year on year. So you may not reach that magic number to begin with, but definitely it will happen in over a period of time.
Yes, the risk there is tremendously high for a person who's going to invest 5 to 7 crores. And if he doesn't reach that figure of 50 to 60, it will fall on his head. So what we have found here is that, like Rupal was training, I have trained lots of doctors in Bombay, and now they have their own centers and they have their own practices and they have got their own examiners. But the first 5 years, 10 years, for example, in 2002, 2004, I had 80 surgeons visiting my clinic.
Wow.
And the highest we have done in a day was, of course, I think 28 patients. May not be equal to many of you in a day, but it was for us quite a high volume. And now all of them have spread out and bought their own machine because over the number of years, they've realized they can get a certain volume, which is self-sufficient, etc., etc., etc. The advantage there is your risk-benefit ratio is calculated. So you know that you're taking a calculated risk of a smaller amount, which is much easier. And if you want to start from day one with an excimer laser and a whole setup of lamellar flow, it is going to cost a lot of money. Unless you have a very, very rich father or a family who's going to give you the money, it's not going to happen. This I'm 100% sure, because when you begin practice, you don't have that many cataract patients coming in. Forget LASIK patients coming in. So word of mouth will come. First you'll have 10 patients of OPD, then 20 OPD, 30 OPD, then 100 OPD. If you start on day one. So it's a completely different ballgame.
Or the other option is that you should basically, like I'll tell you from my own example, because when we started in Pune, now, although I'm second generation, my father practices about 2-3 hours away. And that time, I would have calculated all these things about number of eyes and all those things, I probably would have not started with Smile on the first day. So basically that time we took a huge, risk in that way, because I had taken everything on loan. And me and my wife, now when we think back that how did we take such a big risk? Of course, it has paid off. But the thing is that I think I will agree to certain level with Shreyas. At the same time, in metros, like in Bombay and Delhi, you still have access models. So basically for people, it is not mandatory that they put up their own centers. They can still take access with centers like Dr. Kumar and Dr. Rupal ma'am, and then they can still progress. But yes, definitely. I mean, in the beginning, if you are a core refractive surgeon, then definitely it is worth investing in all these equipments. Otherwise, you can always take access. And when we come to the access model, my next question is to Dr. Rupal ma'am and Dr. Kumar, is how to create access model to be a successful access model. For example, now there are many surgeons who buy their own examiner. Maybe they don't have the volumes with them, but they rely on other doctors to get their patients to their center and then perform LASIK surgery at their own center, so that their own volumes are decent and it is viable. So what is the success mantra for creating an access model?
So one thing I think you have to be careful about if you're going to make it as a free access center is that there is no branding of your own self there. And if possible, it should be in a neutral place, which then acts as a LASIK center and not Dr. Rupal Shah's clinic. Right. Should at least not say that or even project that, because that would make people feel more comfortable about going to that place. Also, there should be transparency in the way things are dealt with. So in a city, sometimes it happens that, so especially the price or what you quote to the patient. So if the patient comes directly, if he's quoted one amount, and then if he comes through another doctor, it's being charged something else. Then in a city, especially a small city, the patient can go around shopping, and then it creates a very bad vibes between doctors, because then they are competing against each other for the same patient. So that should not occur. So there should be fixed policies. There should be, if possible, a neutral person managing the center who is preferably not a doctor, because doctors are poor businessmen and most times. And it's also that you need somebody who has idea about what exactly is happening in that center in terms of the footfall, the number of patients that are entering, the number of the equipments, whether they are well maintained, whether the staff is coming in time, going in time, is doing work in the center and not really doing something of their own, to also upkeep of the place. So if you have a manager or somebody who has interest in that particular center, that would help. Anything else, Kumar?
Anything to add, Dr. Kumar?
You are absolutely right. So there are 2-3 things I'd like to add. One is I'm also running somewhat a neutral center, but it's my private. But as you said, there's no my branding there. First point.
Yeah.
Two,
It's at a different, not in your own main hospital. And
no, it's in my main hospital.
Yeah, so I think it's slightly different because Dr. Rupal ma'am has it in a neutral center.
Correct.
This Dr. Kumar has in its own.
at least when we started, we had made sure that it's not getting any of my name.
Branding, correct.
So actually, Rupal's formula is a more successful formula or a more correct formula, which makes everyone more secure. But 2-3 things I'd like to add that another doctor's patient who comes will come with relatives. And sometimes I get a request, okay, ye father ka bhi aankh check kar lo na yahan pe. So we refuse that. Okay,
Yes.
we don't allow that. 2, the patient and the doctor both have to be told very clearly that the patient will come in the evening for follow-up to your center. 3, the consent form will not have my name anywhere. So it's only that doctor's name. So technically, legally, liability-wise, I'm responsible only for sterility and functioning of the machines, and that's where my liability ends. The rest of it is entirely done by the doctor who gets the patient. And 3, in that also there are people who undervalue themselves. So we as doctors should send out a message very clearly that if a senior doctor starts charging a patient, say 12,000 rupees for 2 hours of LASIK, because you're getting a patient to me, is sometimes, I think, quite sad and stupid. The main reason being, that's not really the calculation. If we really sit down and calculate how much we are spending per patient, is significantly higher. Rupal is more experienced than me, but it is a cost. It is just not the cost of a blade or a microkeratome.
Exactly. Short-sightedness.
And it's just not a gas. So things like this, all the seniors and all the juniors should get together and make value for your own self, value for the procedure, so that certain value is maintained. This is actually a take-home message for all young people, that do not try to undermine to get volume, because you're compromising somewhere.
Yes.
If we can get this across, it will be great.
Absolutely. I think great pulse. So now the next question is for both our marketing experts, Shreyas and Ritika. I think there are no better people than both of you to give pulse about the most effective marketing strategy from your own personal example. Like what has worked for you, why it has worked for you. If you have tried everything, how have you tried everything, and what has worked and how it has worked?
Right. Yeah, Ritika can start.
I'll start with Ritika. Yeah.
Okay, so we've been fortunate to have leaders in refractive surgery who've created a word of mouth. But that said, word of mouth is created over decades. So for youngsters, it is basically shortening the word of mouth by amplifying it, wherein the marketing comes into the play. Because, we can't wait 20 years for because at possibly 20 years ago, there were very few refractive surgeons. Being a refractive surgeon itself was a USP, and there were individual brands that were built. There were very few phaco surgeons also. So now having technology is no longer the only differentiator, or being the refractive surgeon is no longer the differentiator. So hence marketing is necessary to create that amplification of your word of mouth. So I feel what has, you have to continuously evaluate what's working, because what was working 5 years ago is no longer working now. We started with search engine optimization, because you have to be visible to patients who are searching for you. Then we moved to Google ads and Facebook ads. Ever since the health tech companies have come in, you now have Pristine, Hexa Health, Taka Health, all of them bidding so high that your cost per lead is going into thousands. So then you have to reevaluate it. Possibly what works better is vernacular, because, or location based, or YouTube videos, which, we've had a colleague who's had stupendous success with that, because their Pristine or a Taka or in any health tech company doesn't have the expertise. So the YouTube video again works. So these are the marketing things. What I realized over a period of time is to make it scientific. For that, you have to capture all the data. Otherwise, we are basically a lot of the time basing our success on pure perception, because we are sitting in the clinic ourselves and thinking that this patient is saying this, right? And therefore, you have to accurately capture the data. Where is this patient coming from? Your callers, sometimes I call it the L1 syndrome. You don't want to invest in callers. They're sometimes on minimum wages. But I have a counselor. We changed our LASIK counselor very recently. Now, what she does is she calls the patient 1 to 2 days after the refractive workup, because a patient is shopping in that time. Because if you see, a lot of the patients sometimes don't take the date, and we normally used to call them 2 weeks later. By that time, they've done their shopping and sometimes even got a discount deal. She simply calls the patient 24 hours to 48 hours later that you had dilating drops put in your eye. Did you face any problem or allergy because of that? Are you comfortable? For any further queries, I am accessible to you. Here is my number. So the call comes as a caretaker call, not as a commercial call. And with that one call, we had 2 returns every week. So marketing is nothing unless it leads to a conversion, a lead. Marketing basically gives you lead, it doesn't give you patients. So a lot of the time we spend a lot of money on marketing. I actually reduce my budget at times because we are getting so many leads that we can't follow them up. And you will get irrelevant leads also. So you have to feed back into the system that this is giving you irrelevant leads, even if it's cheaper. So that feedback mechanism and that scientific evaluation has to be there. There has to be a person who is doing your online reputation management, because as Dr. Kumar sir said, that there are robots who can give you fake reviews. People can post anything about you online. They can boost anything. So you have to manage your sentiments. It does not take time. There are automatic, tools that this is your sentiment analysis. This is your website traffic. And it is a very good way to predict your possible revenue pipeline by seeing the number of calls you're getting, the traffic your website is getting, so these are all passive indicators of the active revenue you will generate in the coming months. So I feel that it should be scientifically broken down. There are simple things that you can do. For example, we ran a free LASIK workup campaign, and we then thought that the patient is trivializing the workup because we did not want to give a discount on surgery. So we thought, let's reduce the free LASIK workup and make LASIK workup at 500 rupees instead of 2,500. We realized that our cost per lead increased by 2,000 rupees. Oh. Because the free LASIK at 500 was not as appealing to the patient. So I am actually losing 1,500 rupees. So this is a beta testing that you do for your Facebook ads. Okay. So I would recommend that digital is actually great for the smaller practices also, because you can shrink your radius, you can do beta testing, you can do YouTube videos. And it in fact gives an advantage to the local practice over the corporate, because you can use a vernacular language, because the tonality of a corporate sometimes has to be countrywide, and it helps you connect to the local audience. So you have to, and I love looking at what other people are doing. You should look at your competition as your inspiration, because you don't have to copy them, but just the fact that everybody's working hard pushes you to work harder. So that's pretty much my endpoint, and marketing helps you amplify. If you're spending 3 crores on a machine, or even 5-6 crores on a machine, if you can make it reach double the revenue by spending 1 crore, that's a worthwhile investment. So like Dr. Anaga said, you should park a certain amount of money which you will spend in marketing. What works also is to do a digital campaign works better if your brand is recognized. For example, if you're doing a radio campaign or a TV campaign, Shrey would second me on that, and you're doing digital, See, if today Marks and Spencer gives a discount sale, we will go for it. If Tommy XYZ, which we don't know, has as good quality but gives a discount sale, we will not go for it. Because, right? So it's not about the discount, but it's about the brand recognition. Once a recognized brand is, visible, you're more likely to, your clicks will be better, the intent of the lead will be better. So that is a parallel investment. So I think that
I want to ask you something that, so what should be your marketing budget? Should you calculate your cataract, retina and LASIK revenue? Or should you calculate your LASIK revenue and calculate a percentage of that? Or how do you allocate a percentage to the marketing, and how do you know that your return to your allocation is happening? How do you keep a tab on that?
Basically, the marketing budgets for all chains, including multi-speciality, varies from 3% to 10%. Basan had it as high as 13-14% because their doctor costs was lower. So we normally keep it in a single digit, the marketing budget, but that is of the total revenue. If you look at Refractive today, if you speak to people like Practo and Pristine, their cost of customer acquisition is 30% of the surgery cost. So that is how high it has become because it is competitive. So my personal cost was coming to about 10 to 15%, and my marketing team was thinking that it's costing us 10,000 rupees to get you a smile. I said, don't worry about it. A smile is going to pay 1 lakh plus extra. So, and as you do more and more of it, you can refine it. So you may have a single digit cost for cataract or total, but it cannot be single digit for refractive unless you have a goodwill of 20 years. And even if you have a goodwill of 20 years, I think market share makes a difference because the more and more people, at a critical mass, the amplification becomes faster. And you're also losing market share. If you have 20 years of goodwill, you don't want to lose market share. So it is sometimes, the only thing is that there are a lot of people taking shortcuts. So to educate the janta it's costlier than to fool the janta. So that is the truth of
marketing.
But if you are truthful, the beauty of refractive surgery is if you're authentic, you will last longer. So the discount deals and the the false marketing, it is getting visible. But you do have to spend a lot of money. There is a lot of noise in the refractive space. So 10% say come cost of customer acquisition nahi aayega. Because there's so many people and doing different things. And I think 10% makes it viable as long as the doctors don't undercut the cost of the procedure and doctors stop doing miscommunication. That I think those are the two things which are my wish list. Then refractive surgery will be very lucrative.
Absolutely.
So
Shreyas, anything to add?
Yeah, I'll keep it brief. It's 10:30. I'm not sure how many people will be listening to our advice on marketing. But I think first and foremost, if you're living in Delhi, Bombay, or Bangalore, move out to a smaller city. It definitely helps. You will set up a much larger, faster, bigger practice and acquire a lot more patients in a much shorter period of time. Because the reason I'm saying this is, I mean, obviously I'm not asking you to move out, but the idea is that while we think that, affordability is better in tier 1 cities, they're actually, it's not true. And they actually think about the costs a lot more than they do in tier 2 cities. India today, people are willingness to spend on healthcare as a product itself is greater in tier 2, tier 3 cities because they spend on less on other things like, let's say, partying or clubbing or etc. etc. So definitely youngsters, along with the support of their parents, are able to do so. Marketing does vary a little bit from place to place, location to location, whether you're in a larger city versus a smaller town. But the tenets remain the same. So obviously, digital consumption has massively increased, and there's a lot we can talk about. Discounts and other offers to begin with, I won't discount the discounts in a sense. Definitely, it is useful to start to attract a certain number of patients to reach a certain critical mass so that you have a baseline from which you can grow. So many of our centers initially required a lot more discounts to pull in and attract patients. But after a period of time, you're able to stop those discounts, and you still are able to maintain those numbers even though you have stopped those discounts. It's because only then to reach that word of mouth, to reach that critical mass, you need to have something extra thrown out as an incentive for the patient to walk into your clinic. So definitely to start with, it helps. Important, very, very important patient information, patient education videos. And definitely, I think YouTube videos go a long way. I think for us, a new market like Kochi has been one very big example for that. It did not help us in the first month, did not help us in the third month, did not help us for 6 months. But for almost a year, we kept at it. We kept producing videos, kept making videos, kept displaying those videos. A couple of doctors and staff were very good and adept at it, kept communicating very basic things, simple things, what a patient would be apprehensive about, what we would think is not really important. Those 2-3 minute videos, we had a good agency, marketed, boosted, increased the number of views. And now we are reaping the benefits of that, because we can see that a lot of those patients are who, when we ask each time, and that's very important, ask every single patient about the source, about how they got to know about your hospital, about your this thing, that adds a lot of information. And a lot of them do point towards those YouTube videos. It may not be the single factor. It might be word of mouth, it might be your satellite ad, it might be your newspaper ad, a combination of factors. But that is something which has resonated with them. And that is one thing which might have, apart from the brand recall, it is also that video which has made them choose you over XYZ. So I think that makes a big difference. And like Ritika said, a Practo or a Pristine or this thing would not be able to do those videos, which as a doctor you can, and definitely put forward, and definitely spend time in doing it. Make appropriate length of videos, shorten the duration, don't make it too long. 2 to 3 minutes is supposed to be ideal. Put some animations on it. Don't keep it monotonous, not the single person talking as a didactic lecture. Put in animations, pictures, videos, this thing which really helps. So it might feel like a waste of time to begin with, but definitely pays out in the long run. It's not immediate this thing. People think that digital, you bombard on digital, you'll get immediate returns. That definitely does not happen. And it requires a long sustained effort to keep doing it. So even if it doesn't work in the first month, third month, don't be disheartened. Keep at it. It will definitely work in a period of time. The duration may vary from center to center. We might be able to crack it in 3 months in a tier 2, tier 3 city, but in a tier 1 city, it might take 1 year. So, but it will definitely work in your geography, and you can make it target specific, location specific, population specific, define each of your this thing. I find Google, YouTube to be more useful than social media. Social media, both Instagram, Facebook, while useful, Facebook, I don't think it's of that much use anymore, but Instagram is of some use, definitely, to get that kind of population into your clinic, to get interested in your this thing. So keep posting regularly on it. And it also helps to have some influencers. I'm not talking going overboard with very expensive high-end influencers, but your own patients who are young, you will not recognize, are actually quite popular within their own circle on Instagram and this thing. A short testimonial by them posted on their own page definitely goes a long way. So getting a lot of testimonials and reviews from patient, posting it on appropriate platforms, Google reviews, testimonials on Instagram also really helps. These are all short, cost-effective ways of getting the word out and generating leads, as we put it. Apart from that, a regular budget, like Ritika said, is definitely important. And keeping on reminding within that same population through different things. Like normally, you suddenly think hoardings are a waste, or a newspaper ad is a waste. But unfortunately, there is no bad marketing. Everything has an effect in its own way. There is a brand recall in its own way. You might think for that particular season, that particular month, it has not helped, but it does help in the long run. So having a spread of your activities is also very important rather than putting all your eggs in one basket. So that's another thing which I've learned in certain player locations, that when we spread it across different things, it all adds to the overall exposure and brings in better footfall.
Great. So I think very quickly from all 5 panelists, if you can tell what is the percentage of your marketing budget compared to the revenue. So we'll start with Shreyas. What was last year your marketing budget compared to your revenue? Percentage.
6%.
6%. Ritika?
Yeah, we're exactly the same, but that is also total revenue.
Total revenue, 6% of the total.
6%, this does not include the launch of a center. I mean, if we are launching a center, then that's a separate budget because we do give it away. This is for existing centers.
Okay. What about Dr. Kumar?
I've applied for a loan.
But like what? 10%, under 10%?
No, I'm nothing. I'm not even 1%.
Not even 1%. So what about Dr. Rupal, ma'am?
So
She doesn't need
I don't do it myself now. I have experts to handle.
to handle.
Yes.
What about Dr. Anaga?
Maybe around 5%.
5%. I think Dr. Anaga is dealing with, especially in cataract, very high volume of cataract.
Very high volume cataract.
So can you very short, like 1 or 2 minutes, tell about the success mantra of your center?
You're asking me?
Yeah.
There is no success. I think the most important success mantra is hard work. I think maybe I just put in my life and soul into it. So I don't know. I mean, it's just that everybody is doing digital marketing, but somehow what I think that how you resonate with your patients, no,
Right.
that bond that you have with your patients. I think maybe this side of town, I'm not into actual proper Mumbai, but it's one of the peripheral suburbs. And fortunately or unfortunately, there, the kind of relation that you develop with your patients means more to them. Yes.
Right.
So I think basically, just one last thing I wanted to ask everybody. If you compare the growth of cataract practice versus LASIK practice, do you think your LASIK practice has grown to the same extent as your cataract practice?
Or more, maybe.
No, just a quick question. That's all.
I think for us, the femto cataract actually helped. The ATV of cataract is increasing very significantly now, the average ticket size of cataract, because there is a greater adoption of even like the extended depth of focus lenses. So the price points are moving upwards with the femto cataract, and the cataract market is giving you a lot of value driven growth. So also for the newer technology of SMILE and refractive. So we had a slump in Delhi because Delhi, you know, is the hotbed of marketing of refractive surgery. So we actually did have a slump in our refractive in COVID because I think we were a little disorganized because there was no trending in terms of number. But if you ask the industry, the refractive practice has significantly grown in value and volume. And given the fact that myopia is increasing, and people are now at home, so the market scope study is also saying that refractive will overtake the refractive percentage growth is going to overtake the cataract volume percentage growth. Value wise, both continue to grow.
But there is a big difference in investment to value to return to ratio. So
Yes,
your
sir.
investment in refractive is far higher than your investment in cataract. So the growth comparison again will be a tricky comparison because your growth in investment is also much higher.
Sir, but if you have a multi-doctor, multi-location practice, they're not mutually exclusive. What happens with high volume cataract surgeons is that their time is limited. So if you have the opportunity to expand your bandwidth, the practices are synergistic. It's only the choking of the bandwidth that is the problem. For that, you have to develop a system and hence depersonalize. Whereas that is why I was talking about the data and the systems, because it gives you visibility over perception.
Also, I think it depends on what your focus is.
Yeah.
If you're more focused on refractive surgery, maybe there.
One question I would like to ask, as a general ophthalmologist, a person who walks in the early, just after passing out and having a refractive fellowship done, which is the startup machine which you would recommend initially? Or does he go directly for the Contura or this? What exactly is your advice? Each one of you chip in. And this is the final, I think, the question we can take in. It's almost 1 hour, 45 minutes. So it's great going to give a step-by-step answer, which tier 1, tier 2 city, how much loan, which finance option they should take, and what are the other equipments parallelly to start up a base refractive practice. Yeah, Rupal ma'am. First, we
It's
start
very
with you, then
difficult
Kumar.
to say. Depend upon which market you are in, which city, how many other centers are there, what is your capacity to invest, what you envisage as your practice. There's so many factors which come into picture. So you can't really say that, okay, you need a particular brand of microkeratome or a particular brand of excimer laser, but basically you would need a good excimer laser, a good microkeratome, and a good diagnostic equipment to begin with, at least a tomographer. And then from then on, you can maybe add on depending upon how it is in your situation.
Quite right. Yeah, any inputs from Kumar? Your view and the rest of the panelists also. Quick answer on that. And before we wind up, if Vardhaman has got any questions more.
No, I have one last question after this, and then we'll wrap up.
Yeah, Kumar?
So as far as the examiner goes, I'm a great fan of the Schwind because of many reasons. As Rupal said, you need a wavefront analyzer, you need a pentacam or anything equivalent which gives you a posterior flow to cover yourself legally. Microkeratome may not have a great future, but you should have it because there are some patients who can't afford it. So lots of us do surface treatment and wrap it up. So your examiner should be able to do the latest smart pulse or whatever technology that you have. And if you can invest a little more, then to do SMILE is also a necessary investment that would be necessary.
Great.
So
Yeah,
I think
Anaga?
Could you, as a first generation, actually, like I would possibly be a little timid to start immediately after entering practice, a refractive practice, because there is a lot you learn from how to deal with the patient, how to manage your finances. And perhaps if you started too soon, you may fail and never start again. So if I was coming fresh, I would possibly, and I was the first generation, I would possibly invest a few years to understanding myself, my patient, my finances before buying such an equipment, because sometimes we have a lot of equipments that are for resale because there are people who invested in it, and like a lot of first generations have to do, the cataract practice has to cross subsidize the refractive practice. So too soon or too late, I mean, you have to balance that out. But to start as a nobody, as a novice in terms of practice, may be a little tricky. What would be my opinion?
No, that the other people.
We started like that, Ritika, but I think it helps to marry somebody who knows the business.
That's what I said, a first generation with no background in terms of father, husband. So if you're just on
We
your
started just like that. There was no background, too young, too inexperienced, too not unknown.
Yeah, but
Right.
we have quite a competitive market because the number of LASIK machines for resale is actually increasing for certain people who just gone in too soon.
so.
Yeah.
Yeah, so I think one.
Yes, and Anaga.
Yeah.
Before,
Yeah, sir. I think we have covered. In fact, I would like to just congratulate you for bringing out such a lovely topic which has not been touched upon. We always talk about how to do LASIK and all that, but these things are not
We
talked about
talk about
anywhere.
complications in LASIK.
Complications and your advances, but I think this is something which is so basic and yet very not well covered. Thank you so much for that, actually.
Thank you to Moscow and all of you.
Yeah.
So I think at the like this is probably the conclusion. I was planning to ask question about the medical lawsuits, but the thing is that I think one has to be careful. I think I'm not going into that question because in US this has become number one for ophthalmic subspecialty. This is the most prone subspecialty when it comes to refractive surgery. And I think keeping your consent forms very well, and of course I give my consent forms to the patients at consultation itself, so that they are aware. So don't hide any complications or risks of the procedure. So basically, to conclude, of course, as we have seen, setting up a refractive surgery is a practice which is a combination of right training, technology, team, and temperament, as Dr. Rupal ma'am has said. It is a dedicated subspecialty, and it demands a good understanding of science, art, and commerce of refractive surgical practice. And of course, once mastered, it is one of the most gratifying subspecialties, both psychologically, clinically, and also commercially. So thank you again, Dr.
Yeah.
Taswara, sir, for giving me this opportunity. And thank you all the panelists, Dr. Rupal ma'am, Dr. Kumar, Dr. Ritika, Dr. Shreyas, Dr. Anaga, and the
Thank
whole
you.
team, Dr. Rajesh and Dr. Rajiv, for this webinar. Thank you.
Yeah.
Thank
Before
you.
that,
Thank you so much.
Thank you.
we'll have a quick
Thank
closing remark. Thanks each one of you,
Thank you.
especially Dr. Rupal ma'am, in spite of a busy practice, on a single phone call, she was ready to do this, and she has done a fantastic. It's like a master class for all the people who have joined. The audience are very lucky to have this session, as Ranaga rightly pointed out. This has never been covered. I just researched it and said that this has to be done, and we had the fantastic panelists, and what a lively interaction. I'm awed with Shreyas and Ritika. The amount of knowledge they have about marketing is absolutely tremendous and stupendous. It's going to be put to good use by each one of you listening. And of course, Kumar, Rupal, and Anaga, their valuable inputs as the real masters in this blessing. Vardhaman doing an excellent job trying to extract maximum info from each one of you. And of course, the audience who has joined in today, yeah, they are damn lucky to have such lively discussion. We are again thankful to the endured people. We'll have a quick gallery view shot. Keep your videos on for posterity. We'll be uploading on the MOS website. Thanks everybody for joining. And let's have a gallery view shot, Anmol, quickly, and your video, entered video, before we sign off. I think official Thanksgiving usually Rajesh does it, so we'll allow him to do that too also quickly. Yeah, Anmol.
Yes, sir. Taking gallery view shot.
Yeah, please, everybody smile, because the smile is the technique of future. Are you done?
Yes, still smiling.
Yeah, everybody's just smiling.
Gallery view done, sir. We are playing the video.
Yeah, quick 1 minute video, and then we have Rajesh for an official Thanksgiving. So it will be a triple Thanksgiving for each one of us. Yes, Rajesh.
Yeah, we can go on and on as far as discussion on refractive surgery is concerned. May it be a starting refractive practice or its complication or whatever. Thank you, Dr. Rupal Madam, for highlighting on integrities of starting refractive practice. Your talk was to the point, and I'm sure it will be helpful to young ophthalmologists who want to add refractive surgery to their practice armamentarium. Thank you, Dr. Kumar, Dr. Shreyas, Dr. Anaga, Dr. Ritika for giving valuable inputs. Thank you, Dr. Vardhaman, for conducting the sessions so well. I'm also thankful to all those who joined on virtual platform, and thanks to Entor for the technical support. Thank you all, and good night to everyone.
We had a marathon session today, but it was
Thank
good.
you.
Yeah,
Both
it was
we
too
didn't
hard.
realize. Suddenly, when Kumar and this Shreyas were saying it's already past 1 hour and 30 minutes, I realized we had passed that time. But it was very, very interesting. Each one of you so lively, and the control on your this thing that you have, the language, the way you put it across is commendable, Baba. We have to learn a lot from you people.
I think Vardhaman also did a really good job.
Yeah, he's tried to take out
I had-
extractive questions.
I had
That's right.
amazing panel. I had amazing panel. So I think if it was my choice, it would have gone on and on and on.
Yeah, we would have, even I wanted it, but it's almost 2 hours
Of
now.
course. No,
So
but
that's
Naman had all
thank
the
you, everybody.
answers, but he was just asking the questions.
No,
Yes.
no. It is always great to learn
Well
from
done.
everybody.
Dr. Jignesh, congratulations. Well done.
Thanks a lot for appreciating it and being part of this wonderful show. Now, all this is going to be uploaded on the YouTube as archives this year, whatever events we have done. And this is, I think, one of the best webinars I have attended in that 150 that we have completed till now.
Great.
So it was too good.
Okay,
Okay.
good night, everyone.
Thank you. Thank you.
Thank you, sir.
Yeah,
Bye.
thank
Take
you.
care.
Thank
Good
you.
night. See you
Good night.
again.
Thank you.
Good night, Ritika. Good night,
Thank you, sir.
Shreyas.